Again, a very warm welcome to you all to this channel. And we were talking about the cornea and we were on bacterial keratitis. We'll start on the treatment and the um, treatment as well as some other topics on bacterial keratitis. Let me just give a recap. Like the most common cause is staph aureus. Most common cause in India is staph epidermidis. Okay, resembling fungal infection is nocardia, and after refractive surgeries, most common cause of bacterial keratitis is Mycobacterium jeloni, and someone which is causing us ulcer, a serpentine like ulcers, which is basically the pneumococcus. And when you just examine, what you see is you see this corneal edema, right? And you see this sterile hypopyon, you see this desmus membrane fold, and what you see here, what is this beautiful structures, what you see here is actually the fluorescent stain positive ulcers, right? And now what you need to remember is keratitis can be associated with uveitis. Now there might be a perforation, there might be a localized, there might be sludging ulcer. So whenever this term comes sludging ulcer, you need to always remember that sludging ulcers refer to the pseudocornea because of the excess amount of pus. It resembles pseudocornea. And perforation, it's because of pseudomonas. Okay, pneumococcus is serpentine necrosis. Often we get confused in this one. Okay, and next thing what you need to remember is in the investigations, what are we going to do? Of course, you need to remember about the leukoma adherens. So what is leukoma adherens? So whenever there is a perforation in the cornea, this iris tends to just go and obscure this obstruction. It just blocks this obstruction, and that is known as leukoma adherens. And this leukoma adherens is a classical features when you see in the case of your perforation because of pseudomonas. Okay, and what you need to remember here is the investigations. In the corneal investigations, what are we going to use? We are going to use Kynorus spatula, and we are going to go with the gram stain cooked meat agar broth. You can also go for certain like different types of media like McConkey agar, or to look into the gram negative bacterias, a nutrient agar. You can just cultivate in the nutrient agar if you want to. If expecting staph aureus, you'll be seeing some this yellow colored colonies, okay, as you have studied in microbiology. Now let's come to the treatment of bacterial keratitis. So the very very important aspect of bacterial keratitis is its treatment. So what are we going to do is we are going to learn about the empirical therapy. Let me just increase the thickness of the pen. Okay, so we are going to learn about the empirical therapy. So in empirical therapy, what we are going to learn is we are going to learn that the most common drug is used is moxifloxacin. So you can also use gatifloxacin, and also basifloxacin, but the most well deserved, okay, very nice drug is the moxifloxacin. Okay, and you can also use antibiotics. Antibiotics can be used according to the culture. So if anaerobic is there, you use an antibiotics accordingly, maybe a metronidazole. If aerobics are there, whether it is a gram positive or whether it's a gram negative, on that basis you'll be using the antibiotics, right? And you can also go for a duo therapy. So what do you mean by a duo therapy? You are covering both gram positive as well as gram negative. So you are not taking any kind of risks. You are covering both gram positive and gram negative. And the best drugs that we can use here is the cefazolin. You have to remember this, okay? Cefazolin with gentamicin. You don't need the doses and all, but you need to remember the names, okay? Gentamicin. So cefazolin is a cephalosporin, gentamicin is aminoglycoside. So you're going to combine these, or you can also use cefuroxime, and you can also use gentamicin. Okay, so cefuroxime and gentamicin can also be used. Okay, and this antibiotic ointment, you're going to use it at night. Antibiotic ointment, you just use it at night. There's like this kind of like this ointment, you just use it, like a kajal. Okay, you just use like a kajal in the night at the down of your eye. And what you need to remember is you can also give subconjunctival injections. injections. And you need to remember that I already told you that keratitis is associated with uveitis. Keratitis is associated with uveitis, and when it is associated with uveitis, you need to give cycloplegics. You need to give cycloplegics. And what you are going to give? You are going to give mydriatics. Okay, mydriatics. Okay, and oral anti-inflammatory drops can also be given. Okay, and you need to also remember that vitamin A, vitamin C contain supplements for healing for ulcers. Okay, and we can use this. Okay, and very very important. Okay, very very important, if you see that the cornea is thinning, okay, thinning, then you have to give two drugs, very very important. It is tetracycline and doxycycline. Please make your notes. Okay, please make your notes, keep on writing. I have studied this almost 2000 times, I think, but also I get confused. Okay, keep on memorizing it, keep on studying it, then only you'll understand. Okay, okay, so I think you're clear on this. So we are always talking about the empirical therapy. In the empirical therapy, moxifloxacin, gatifloxacin, bcfloxacin, but the most preferred is moxifloxacin. In the antibiotics, we can always choose for anaerobics and aerobics. For aerobics, whether it's a gram positive, gram negative, this all on basis of your culture. And what you need to remember, you need to remember the duotherapy. In the duotherapy, you have gram positive, you have gram negative. So you have cefazolin and gentamicin. You have cefuroxime and gentamicin. Okay, and you can also use antibiotics ointment. And for the subconjunctival injections, you can also use that. Okay, and I already told you that keratitis can be associated with uveitis, and in that component, we talked about perforating, we talked about localized, we talked about sludging ulcers. In sludging ulcers, I talk about the pseudocornea because of the excessive pus. I also talk about leukoma adherens in the case of perforation. So leukoma adherens. Okay, okay, great. Now let's talk about the fungal keratitis. Now, whenever we talk about the fungal keratitis, okay, before fungal keratitis, I want to talk about the management of non-healing ulcer. So there's an ulcer in your eye, and that ulcer is not healing. So there's a saying that never give steroids. Okay, steroids are very much contraindicated in the case of ulcers. Okay, because it might lead to other complications. Okay, and if there is ulcer, so how are you going to manage? Like in surgery also, suppose there's an ulcer anywhere, okay, let me use a red pen. So there's an ulcers anywhere, and in surgeries also, what are we going to do? What do we do? We just debride these dead tissues, right? We just remove these dead tissues. So here also we are going to do the same. We are just going to remove this dead tissues, and after removing this dead tissues, what are we going to do? We're going to give it nutrition. Okay, nutrition is required. So anywhere when there's an ulcer, when there's a disease, when there's a trauma, anything, the most important is the nutrition, right? Here also what we do is we just debride. So debride the necrotic tissue, give nutrition to the affected part. Now, how are we going to give it nutrition to the affected part? Okay, so we are going to use this oxygenated lens. Okay, high water content means more oxygen transmitted to the lens. So what are we going to use? Is we are going to use bandage contact lenses. Okay, bandage contact lenses. That means when we use this lens, this is actually, these type of lenses it consists of high water content, and it is soft or semi-solid. Do not use hard banded contact lens. Okay, hard is never used. Soft or semi-solid, and this type of soft and semi-solid lenses, if we use like this, Okay, suppose this is your cornea, which is ulcerated, and this is your lens. Okay, so whenever we use these type of whenever we use these type of lenses, then there is a high water transmissibility inside the cornea. Okay, high water goes inside the cornea, because of which there is healing. You might be thinking that cornea high water goes inside, it might lead to corneal edema, because I already told you that the endothelium, they are preventing the water entry into the cornea. But here I'm just talking about the epithelium. Okay, so the epithelial has been eroded, the superficial epithelial layer has been eroded, leading to an ulcer, and we just want to treat it, right? And what we can do, one more thing is, we can always go for a Gunderson's conjunctival flapping. Okay, so suppose if this is a cornea, here is your ulcers, you just take this part of your conjunctiva and just you flap it around. Okay, like from here you just go here, and that is known as Gunderson's conjunctival flapping. Gunderson's conjunctival flapping. Okay, this is very important. And next thing what you need to remember is, so if there is about to be perforated, if already perforated, then you have to go for, of course, you have to go for your, you might always go for therapeutic keratoplasty or a penetrating keratoplasty according to the requirement. But if there is corneal thinning, we are of course going to use tetracycline, right? Because these tetracycline group of drugs, they have anticholinerase activity. Okay, anticholinerase activity. And one more thing, like over here I told you, whenever I was talking about bacterial keratitis, that if there is corneal thinning, then we are going to use tetracycline and doxycycline, right? Similarly, why are we using tetracycline? Because of the anticholinerase property. Okay, and so if there is impending signs of perforations, what does that mean? What do you mean by impending signs of perforation? That means it's about to get perforated, but it has not yet perforated. Okay, it is about to get perforated. So in that case, in that particular case, we are going to use an anti-glaucoma drug. Now, why are we using anti-glaucoma drug? To reduce the intraocular pressure, right? And we can also use cyanoacrylate glue. Okay, cyanoacrylate glue. Why to use cyanoacrylate glue? If perforation is less than 2 mm, but if it is more than 2 mm, you have to go for therapeutic keratoplasty. And on therapeutic keratoplasty, you have a long class. Okay, I'll be taking that, don't worry. So I think we are clear till here. Bacterial keratitis, are we clear? All the contents I've already mentioned on bacterial keratitis and non-healing ulcers, I think we're clear. Now let's go on to the fungal keratitis. So in fungal keratitis, what do you need to remember? The most common bacteria resembling fungal keratitis is nocardia, as I already discussed this question initially. Now I want to talk about the different types of fungi that can cause fungal keratitis. So what are the different types of fungi that can cause fungal keratitis? Okay, so the different types of fungi that can cause fungal keratitis, they are Candida albicans, they are Aspergillus fusarium. Okay, so Aspergillus, Candida, and fusarium are the different types of fungi that can cause fungal keratitis. Now, a farmer working in field has redness and has blepharospasm, okay, in his eyes. On cultivation, on cultivation of on STA, what do you expect? One is bacterial keratitis, second is fungal keratitis, third is viral keratitis, fourth is none. So if this is a question, so we have two cues, okay? Pharma, redness, blepharospasm. Redness, blepharospasm, most of the eye diseases, redness and blepharospasm. SDA. Why I wrote this SDA? Because this is subarouse dextrose agar. Okay, the subarouse dextrose agar is a important media for the cultivation of fungi. What is the expected time for the cultivation of the fungi? It's 7 to 14 days. Okay, so it's a fungal keratitis, right? And it happens most commonly to the agricultural host, okay? Because they work in the field, and in the fields, the fungi, they easily penetrate in the eyes. During the time of COVID, because of the excessive use of steroids, irrational use of steroids, there was something which is known as orbital cellulitis. And that was caused by nothing, but that was caused by mucormycosis. Now, let's come to the clinical features. Now, again, you make a diagram. There, I told you about the fluorescent stained cells, about the corneal edema, the sterile hypopyon, okay? I talked about this Descemet's membrane fold. Now, here I'll be talking about some more important aspects on examination. So, what we will see here, the examination features are more than the signs and symptoms. It's said like that whenever we talk about this one. Examination is much more preferred than your signs and symptoms. Okay, that means basically the signs are more than that of your symptoms. Okay, so what you can see in the eye, so you can see that there is, okay, what have I made? This is a unsterile hypopyon. Okay, and what you have here is a dry and a rough ulcers. There is this hyphae. Okay, there is this satellite nodule. Too many nodules, so satellite nodules. Okay, and Weasley's immune ring. Okay, so there's this immune ring which is known as a Weasley's immune ring. Okay, this is known as a Weasley's immune ring. What is this? This is a dry or rough ulcer. This is the hyphae. Dry, rough ulcers, unsterile hypopyon. Okay, and these are the different things that you need to remember. And what are clinical features? The same thing: pain, redness, photophobia, discharge, blurring of vision. Compared to bacterial infection, the signs are more than that of the symptoms. This is very important. Signs are much more higher than that of the symptoms when you compare that with the bacterial keratitis. And on examination, unsterile hypopyon, as I've already made here, hyphae, dry rough ulcers, Weasley's immune ring, WESSELEY apostrophe S, Weasley's immune ring. And what is this? This is a satellite nodule. I forgot to mention here, this is satellite nodule. Here, there might be KPs. What are KPs? KPs are keratic precipitates. Keratic precipitates are also seen in the case of course, bacterial keratitis, because bacterial keratitis can also be associated with uveitis. And remember that these fungal keratitis can also be, associated with uveitis. Okay, a long way to go. There are a lot of things that we need to discuss more on cornea. Be with me, be here. Okay, now we'll be talking about the investigation and the treatment of fungal keratitis in the next lecture.